Hello and welcome to the Evidence-Based Urgent Care Urgentology podcast. I'm Joe Toscano. I am on the editorial board of Evidence-Based Urgent Care and also the senior research editor for the sister EB medicine publication, Emergency Medicine Practice.
And I'm Tracy Davidoff. I'm the editor-in-chief of Evidence-Based Urgent Care. Joe and I have been involved in urgent care practice and education for many years, and we're really excited to bring to you this new program from EB Medicine, the Evidence-Based Urgentology podcast. Our goal for this podcast is to review one of the recent issues of evidence-based urgent care and highlight some of the important things that have come out of that issue, the learning points and potentially practice-changing information from the piece.
We hope that the podcast will be valuable in and of itself, but it'll also whet your appetite to delve more deeply into the issue, to hone your practice, and even get some CME credit.
And even if you've read the issue already, Joe and I hope to reinforce the important points and solidify important concepts to improve your learning as a result.
If you create an account at ebmedicine.net, you can subscribe and purchase the issue. You can check out the interactive clinical pathways they have there, and you can get up to 4 hours of CME credit for completing this one issue. Hey, you've already started your CME journey by listening in.
And you can also subscribe for a full year so you won't miss anything. At the regular price, that's a great value. Be on the lookout for occasional promos, sales, and special offers to make it that much easier. Hi there. We will be talking on evidence-based urgent care today, but first, let's talk about EB Medicine. We'll be at the Southeast Regional Urgent Care Association's inaugural conference on October 24th to 26th in Atlanta, Georgia. For more information about the conference, go to seruca.org. That's SERUCA.org. Be sure to look for us there if you attend. We'll have plenty of EB Medicine swag, and maybe even me and Joe will be there.
Maybe. Yeah, today we're going to talk about the diagnosis and management of acute otitis media and acute otitis externa for the urgent care clinician. The author of the issue is Janine Siciliano. She's an assistant professor at UT Southwestern Medical Center in Dallas. And our peer reviewers are Melinda Johnson, DNP. She's an assistant professor of nursing at the EM practitioner program at Vanderbilt School of Nursing in Nashville.
So today we're going to talk about acute otalgia. This is a fancy word for ear pain, which we all know. Very, very common presentation in urgent care. We see a lot of this. We should be experts on it, but you know what? It's really good to review stuff now and then just to make sure you're practicing at the most current levels. The most common diagnoses for ear pain include acute otitis media, acute otitis externa, which is really what we're going to focus on the most. But there can also be trauma and everyone's favorite, cerumen impaction, tonsillitis, and foreign bodies, especially in kids. Most of these we can deal with in urgent care, not a problem, but be on the lookout for any complications that would require further evaluations and treatment. These are people that you might have to send to the ED or that you have to send as a referral to the ear, nose, and throat specialists. Today, we're going to focus on the diagnosis and how most of these diagnoses can be made pretty much by just history and physical findings alone, no special tests for any of this stuff. And then we're going to talk about some treatment, which we're going to weight heavily on the otitis media as well as the otitis externa, with all the current treatment guidelines that go along with that. And then, of course, we're going to talk about some don't miss complications and wrap it up with some PEDS discussion and the differences between PEDS and adults for these diagnoses. Joe, can we talk about anatomy for a little bit?
Sure. Yeah, it's all about anatomy. A lot of the diagnosis is based on anatomy, so we need to know that. The obvious outside part of the ear, the pinna. I'm not going to talk too much about disorders of that in this issue. And it has all kinds of named parts that I know every time something's going on with the very outer part of the ear, the pinna, I have to look up whether it's the concha or the scapha or what part it is to describe a lesion or an injury to that part. But what we're going to be talking about today is the inner part of the outer ear. I guess you could call it the external auditory canal, internal auditory canal. The lining, the skin of the ear goes partway into the external auditory canal, the outer ear, basically. The mucosa changes just before you get to the eardrum. That mucosa on the inside is really sensitive. The eardrum's the boundary between the outer and the middle ear. Middle ear is that hollow space in the skull that contains the hammer, incus, and the stapes, which vibrate with eardrum movement and transmit that sound into the inner ear. Inner ear has two parts, the snail-like cochlea for our hearing, and then the semicircular canals for balance.
I have to laugh because every time I want to mention something about the external ear, I always Google and click images so I can see what all those little different parts are named. Far cry from when I needed to know it all for anatomy. One of those things you tend to forget, but easy enough to Google now that we have such a thing. All right, so let's talk about the otitis media, definitions, epidemiology, pathophysiology, and complications. So definition of acute otitis media is onset of ear pain in the setting of middle ear effusion with signs and symptoms of inflammation and infection. Now, that sounds kind of nebulous, but it's pretty clear. You have to have signs and symptoms of inflammation and infection to call it otitis media. If you look in there and you just see some fluid, it is not acute otitis media. It is not an inflammation or an infection that requires antibiotics. And we're going to talk about that a little bit more. In 2004, the AAP and AAFP both came up with practice guidelines for the diagnosis and treatment of otitis media, which they amended in 2013, narrowing it a bit, really specific otoscopic findings to make that diagnosis of acute otitis media. Patients must have bulging, they must have erythema, fancy word for redness, or cloudiness of the TM with pain or otorrhea not associated with otitis externa. Now, remember, based on anatomy and pathophysiology, these are two really different things. You shouldn't have otitis media and otitis externa at the same time, unless, of course, you had a cold and went swimming. But for the most part, these are two different disease processes. So you have to have those changes of inflammation associated with the TM to call it an acute otitis media. So just a note though, otitis media, just regular old otitis media, really a broad diagnosis that doesn't really mean an ear infection. Acute otitis media is the standard ear infection. Then there's also serous otitis media or chronic otitis media, which just means fluid in the ear without that inflammation or evidence of infection. And then otitis media with effusion, again, is just that fluid in the middle ear. Suppurative otitis media is another form of acute otitis media, but generally indicates that you see pus behind the TM. And then chronic suppurative otitis media is chronic inflammation and purulent drainage with a perforated TM. So chronic pussy stuff coming out of the hole in your TM. Epidemiology, this is really one of the most common diseases of children worldwide. It peaks between 6 to 15 months. About 50 to 85% of children will have at least one episode of acute otitis media by the time they hit age 3. Problem with this is not so much the infection, but the scarring and the damage that occurs from the infection, which can cause hearing loss, which is estimated to be about 30 in 10,000 people. So think about it, 30 in 10,000 people may have hearing loss related to their otitis media. So it's important that we are diligent about diagnosing and treating this to prevent that hearing loss later on in life. In my lifetime, the pneumococcal vaccine came out and it was recommended for widespread use in children, which started in the 2000s. And this has dramatically reduced the incidence of otitis media because that is the number one pathogen that was causing otitis media at the time. Otitis media is less common in adults. However, adults are more likely to have complications from the infection than the children. So again, we need to have a high index of suspicion and due diligence to diagnose and treat this in grown-ups. Acute otitis media is usually due to blockage of your eustachian tube or eustachian tube dysfunction, which is preceded by a viral infection, which causes congestion, or it can also be from allergies. This blockage causes increased fluid to build up in the middle ear, which is initially serous fluid, but then that excessive serous fluid is a risk factor for developing an infection. So why is this more common in kiddos? Well, your eustachian tubes are shorter, they're less mature, they're horizontal instead of diagonal, which during a viral infection will lead to accumulation of fluid, inflammation, will have decreased function of that eustachian tube, and an increased bacterial colonization and adherence to the tissues, which alter mucociliary clearance. This leads to that bacteria having an influx from the eustachian tube into that middle ear and increases your risk for a developing infection. Again, we said the most common pathogens, strep pneumonia, but then also non-typable H influenza is very common as well. But you can also get Moraxella, strep pyogenes, Staph aureus, and you can get viral otitis media from any of the usual respiratory viruses. The complications of this is mastoiditis or infection of the mastoid bone behind the ear in both peds and adults. And then you can also get extension of the suppurative infection that can go to the mastoid air cells and the mastoid processes, which can cause a really deadly spreading infection that can have a lot of morbidity and some mortality. So your physical findings of mastoiditis plus post-auricular swelling and redness and tenderness and possible fluctuance. But one of the things you'll notice right away is displacement of the auricle. So if you compare one to the other, you'll see that the ear is kind of sticking out compared to the other one. This can become a brain abscess, suppurative labyrinthitis, cavernous sinus thrombosis, and facial paralysis, some of which stuff can be permanent. So you really got to look out for it. Joe, can we do the same with otitis externa and talk about that?
Absolutely. Well, it's not as sexy, I think. Acute otitis externa is an inflammatory condition that involves the external auditory canal. The onset's usually rapid. It says that in the issue, and it does seem like people's ears all of a sudden start to hurt fast. Pain's a big part of the symptomatology, along with a sense of fullness sometimes. Edema of the ear canal and erythema is seen on exam. Patients might have drainage in the ear or otorrhea or an exudate kind of on the surface of the external ear canal. And then if it's really bad, it might include cellulitis of the surrounding skin, the periauricular tissues. It's usually caused by bacteria, and in North America, 98% of cases of acute otitis externa are caused by either Pseudomonas or staph, common skin bacteria staph, but also got to think about Pseudomonas when we're picking antibiotics for this. Acute otitis externa is more common in the warmer months because of increased humidity and people spending more time swimming, things like that. You can get water in your ear when you're taking a shower or a bath too, but just so much more moisture and humidity with our activities and in the air in the summertime. That's a lot more common in the summer. Not really common to see this in kids under 2, so a little difference with otitis media there, but it is more common in older children than it is in adults. Although adults tend to get the complications, elderly, diabetic patients, and immunocompromised adults are at higher risk of complications if they get acute otitis externa. Usually there's some kind of that moisture and some kind of possibly trauma to the ear canal, breakdown of that cerumen skin barrier that leads to the bacterial invasion, and then the infection gets set in. That's kind of the pathophysiology there. Complications of acute otitis externa include malignant acute otitis externa. So it's basically just a case of otitis externa that involves more tissue damage. So you can get necrosis of the ear canal, even invasion of the surrounding bone. Again, patients with diabetes, elderly, immunocompromised patients are at higher risk for malignant otitis externa. Intracranial structures can even be affected. The middle ear and the external ear are continuous with each other. So similar complications, you can actually get invasion of the infection into intracranial structures. Sometimes I actually had a patient with this. We were saying every time we review one of these, we get one of these kind of more complicated or unusual cases. A couple of months ago, a non-diabetic patient had acute otitis externa that by the time we saw him in the ED, his CT actually demonstrated that the dura was kind of pushed in so that the infection was starting to get into the extracranial space, intracranial space, but extra axial space. Again, the most common pathogen for those more complicated cases is going to be Pseudomonas. And then these patients are going to have severe pain or treatment failure. Those are two other kinds of evidence of complications. So, hey, Trace, my ear hurts. What's in the differential?
Well, first of all, I just want to mention living here in Central Florida, we see a ton of otitis externa, either in the pools from the tourists in the pools or even from the beach. So we see a ton of that around here, and it's a pretty painful condition. So, all right. So your ear hurts. Let's figure out what's going on. You know what? Honestly, history should tell you 99% of the time before you even get anywhere near the patient. But like I said, the diagnosis for ear pain is broad, although most will have either otitis media or otitis externa, and history and physical is absolutely key to this. You got to also realize that some people may have secondary pain that's referred to their ear from other places. A couple times I've seen people that came in with throat pain and they actually had an ear infection. And sometimes I've seen people with ear pain and they actually had some whopping peritonsillar abscess or a dental infection, like some impacted wisdom tooth or something like
Mhm.
that, or even TMJ. So, got to think about those secondary causes too. If you look in someone's ear and you don't see anything, think about those
Mhm.
secondary causes. You can also have trauma to the ear. Don't forget about our friend cerumen impaction. I'm probably good for 1 or 2 of those per shift. And foreign bodies, especially in kids that are between the ages of 1.5 to 4, tend to experiment by sticking things in their ears, or their big brother challenges them to do that. So they'll stick something in their ear. A couple times I've found things that were kind of unexpected in a kid's ear that they didn't remember putting things in their ear. And as I said earlier, if you look in the ear and it's really unremarkable, start looking for those secondary causes. Look in their throat, look at their teeth, look at their TMJ, and see if you can come up with something else that's giving that referred pain. So, like I said, key is in the history. So, Joe, what sort of things should we ask in the history?
Well, sure. We're probably not documenting PQRST, all of those things the way we used to now with our new coding guidelines, but it's important to ask all those questions. How bad is the pain? When did it start? Is it radiating? Is it just confined to the ear? And sometimes people with ear disease, it can radiate to their whole head. But and when people start talking about their whole head hurting and their ear, you're going to worry about some of those other things. Presence of fever, toxicity is important in determining the severity. If there's some associated hearing loss, that could be just from some exudate or might represent some deeper damage. Drainage from the ear is important. You're going to suspect either a TM perf, let's say, or a really bad otitis externa if there's actually drainage from the ear. If there's been any instrumentation or even home instrumentation, like a Q-tip or something to try and get some wax out, that's important to determine before you start taking a look. Obviously, if they've been recently swimming or had excessive water exposure, actually felt like there's a lot of water in their ear, that can help make a determination. And then finally, patients with more complicated cases tend to get this on a recurrent basis. So any recent ear infection, maybe treatment failure, if they've just coming off some antibiotics or eardrops for the same thing within the past short period of time, important to determine. Also, if they've had surgery, like if they have PE tubes, a child has had a tympanostomy or something like that. Maybe more of interest, not necessarily in terms of exactly figuring things out, but the presence of hearing aids or somebody who wears earbuds a lot, a little more at risk for acute otitis externa. And then obviously immunocompromised and diabetes, you're going to be a little bit more careful to exclude a early case of malignant otitis externa or more complicated infection. Most patients are going to have pain. Some of the associated symptoms might include headache, decreased appetite, insomnia, hard to sleep with an earache, fever, vomiting. Kids who can't talk or tell us those things, although you can kind of observe, I think, anorexia or insomnia, they might pull on their ears or be fussy or have some vomiting or decreased eating. And those are all bad signs in a kid. Something's going on, little baby. You know, occasionally patients can get pruritus or itchiness in their ear or a sense of fullness without frank pain. Occasionally, you'll see that patient and then be kind of surprised on your exam that they have a whopping infection. And then, of all of those things, high fever, patient with toxicity, you're going to worry, regardless of your diagnosis, that they have maybe a systemic complication from that infection. So, going to ramp up your suspicion and broaden your physical exam and maybe think about a different disposition than sending them home. What's important for the physical exam once you get to that point, Tracy?
Oh, I just want to mention, sometimes I really feel like a rock star when the patient starts telling me about ear pain and I go, "Have you been swimming?" And they look at me like, "Oh, how'd you know?" Because you can really tell the difference based on some of the history findings. They didn't if they say they haven't had a cold, then they probably were swimming because it's probably gonna be one or the other.
Yeah.
All right, so on physical, let's talk about general appearance. Are they sitting there holding their ear and screaming and looking uncomfortable? Sometimes you can see pus dripping out of their ear. Sometimes the ear, like I said, is red and swollen and pushed forward. They look uncomfortable. You want to document all that stuff. Vitals, they have a fever or they tachycardic. Make sure you do a complete HENT exam. You want to go from the neck up and make sure you do all of it. Look and palpate behind and in front of the ear. You want to look for lymphadenopathy. Again, for looking for those alternate causes, you want to look in their throat, you want to look at their teeth, maybe palpate their TMJ and have them open and close a couple times. Do they have any rashes? I mean, do they maybe have a shingles outbreak? Is there redness or swelling of the ear or any drainage, like I said? And then symmetry of the ear. Then you head for your otoscope. You're going to look in that ear. You can use a traditional otoscope, but there's a lot of newfangled devices that are almost like little endoscopes that you could put in people's ears, which are useful. I bought mine on an undisclosed website where they deliver it to you the next day. And I love it because you can really get in there and look at things, and it's got a little scoop on the end if you want to move the wax out of the way. You want to look for any swelling or exudate of the ear canal, rashes inside the ear. You know, some people that have eczema or some people that have psoriasis will also have it inside their ear canal, which can predispose them to getting infections. Erythema, either in the canal or on the TM. Any masses. There are several disorders that cause masses to grow inside the ear canal or on the TM, which are uncommon, but if you spot those, you've got to deal with it. And don't forget our friend, the foreign body. Is the TM bulging? Is it red? Is it perforated? Are your landmarks intact? Can you see the bones of the ear? Is there any fluid that you can notice? Bubbles, bulla. Is there absence of the light reflex? Scarring? Have they had previous tubes? And is there scarring there? And are the tubes present? And if they're present, do they look like they're intact? And is there any fluid coming out of it, or is there pus being pumped out of it? You see that, and it's pretty distinctive that you have an acute otitis media. Pneumatic otoscope. Not too many urgent cares have that, but most studies sing the praises of pneumatic otoscope because mobility of the TM is actually diagnostic of acute otitis media. So you have to have a tightly fitting otoscope and you have to have insufflation device for your pneumatic otoscope. So you squeeze the little bulb like the blood pressure cuff bulb and it puts a little puff of air in the ear and the tympanic membrane is supposed to move back and forth. So if the tympanic membrane does not move, that means that you've got a whole bunch of nasty fluid in there that is diagnostic for acute otitis media. It does require a little skill to be able to use it and a little practice, but if you have the availability to use that, I urge you to look into it. Erythema alone should not be used to diagnose acute otitis media. So if the eardrum is just red, that's probably not an infection. You also have to have fluid and some bulging and some other findings especially in little children. Crying, fever, just being generally upset can all cause redness to the TM that does not necessarily mean infection. In serous otitis media, the patients will complain more of a plugged sensation rather than a pain sensation. That kind of goes more up in history, but I find that a lot of times that's diagnostic for me. When I ask them why their ear hurts, is it plugged or is it painful? Sometimes you can tell the difference between serous and acute otitis media with that. Serous has very little redness. You may see some bulging. Sometimes you may see some retraction. It'll have sort of like a discolored, waxy appearance. And it's very critical to distinguish the two between serous and acute otitis media to avoid those unnecessary antibiotics. And antibiotics don't work for fluid, they only work for infection. There are a lot of really good pictures in this issue. So if you want to refer back to the issue and look at the pictures, or you know what, you can even look online, look at many, many pictures of otitis media so that you get really good at diagnosing and telling the difference between serous and infectious. Otitis externa, again, we swelling of the ear canal, redness and exudate of the ear canal. Yellow or grayish debris in the ear canal may be found with otitis externa. Now, having pus and swelling in your ear canal can also alter your TM a little bit. Sometimes when that pus is sitting on there, it dries and it gives like this sort of, I don't know, macerated appearance to it. But remember, it would be really unusual to have both otitis externa and both otitis media at the same time. Like I said, unless you're living in Florida and you went swimming while you had a cold, you're probably not going to have both at the same time. My point is that it does happen, but it's rather unusual. So be very cautious about diagnosing both at the same time. There is a fungal otitis externa, and in that case, you can actually see hyphae and spores in the ear canal. Probably a little easier if you do look at it under a microscope. If you have that capability, maybe drop a little KOH on there and see if you see it. It does happen. Look for this in people that have otitis externa over and over and over again, or people that have pre-existing conditions like the eczema or the psoriasis. Those people are more likely to have the fungal infection. Again, people who have it over and over again, sometimes you'll see some granulation tissue, some ulcerations, some severe swelling at the external ear canal, and sometimes this will suggest malignant otitis externa as well. So, not too many diagnostic studies, right, Joe? Can you go over that maybe a little bit?
Right. Well, like you had said, history and exam are really going to help us make most of these diagnoses. If we have the capability or have to send people to the ED, like a sepsis workup with CBC, metabolic panel lactate cultures, inflammatory markers like CRP and sed rate are going to be important in those patients who look like they have complicated infections like otitis externa or otitis media, along with mastoiditis, malignant otitis externa, or for worried about sepsis or systemic infection. Those patients probably going to get referred to the ED. Yeah, imaging is also useful in those when we suspect that there might be one of those more complicated infections. Again, probably beyond the scope of most urgent care providers. Some of us have access to CT in urgent care, though, and it's going to be important to get a CT of the temporal bone with IV contrast. That's the preferred imaging study. It might rule out an infection and allow you to send a patient home if you have access to that. Obviously, if it shows a more complicated infection, patient is going to require admission to the hospital. MR is also useful in those situations where the disease, you're worried that the infection or the process has advanced beyond the ear itself into the surrounding structures. Most of the time, that's going to be done in the ED setting, and the patient's going to be hospitalized. There was something in the cutting edge section that might spill over to urgent care at some point, and that's nasal PCR. If you have the presence of certain bacterial pathogens in the nose, those are what you're going to suspect maybe in your case of acute otitis media. And it may help you tailor your antibiotic therapy, but those aren't ready for prime time yet. But maybe we're doing a lot more kind of swabbing and running quick tests in the urgent care. It's helping us hone our therapies. And who knows, maybe someday we'll be able to do that as well. How about treatment and disposition for patients with acute otitis media, Tracy? What's important in determining that and how we're going to treat them?
Sure. Now, a little different between kids and adults. In kids, the evidence supports a watch and wait approach. We're trying to give less antibiotics to kids to prevent some of the long term complications and resistance of frequent or excessive antibiotic use. That watch and wait approach, you can hold those antibiotics for 48 to 72 hours if the patient has non severe unilateral otitis media in kids greater than 6 months. But if they have bilateral or severe illness, you probably should just go ahead and treat them. This is only for healthy children without comorbidities, and you really want to make sure that the parent is reliable in observing this kid. Studies show that most children with otitis media are going to get better whether you give them antibiotics or not. Just giving them the antibiotics, they get better a little faster and their pain resolves a little faster. So that's really kind of the goal of giving the antibiotics. No watch and wait approach in adults. We should probably treat them all because studies have either not been done or really not supporting. and no watch and wait in kids less than 6 months or kids that have severe disease. So if you're a grown up or you're a child less than 6 months, you're going to treat when you make that diagnosis. Everybody else, you can kind of do a watch and wait approach. Probably should consider vaccination status. Kids that haven't been vaccinated for pneumococcus are at more risk for more severe disease and more severe infection. You may want to consider not doing a watch and wait in those kids. And again, make sure they have access to close follow up. If you do watch and wait or you do this delayed prescribing that a lot of us have been doing lately, you want to make sure that they know that they can come back if they have any questions or if they need to be checked again to decide whether or not to start the antibiotics. You're going to choose your antibiotic based on your most likely pathogen and any previous antibiotic exposure. Remember, strep pneumonia and H. flu are the most common. And also remember that there's a high degree of resistance for some of this stuff. So if people have had antibiotics over and over again, you want to make sure that you've asked what the last antibiotic was, how long ago the last antibiotic was, and maybe either step it up to a stronger antibiotic or change it up to a different one that you didn't just recently use. So first line, again, in peds, we're going to use high dose amoxicillin. So that's dosed at 90 milligrams per kilogram per day, divided twice a day. And you really only need to treat for 5 to 10 days. Younger kids or kids that have severe disease, you want to go for that full 10 days. But in people that don't have a very severe infection and are not particularly sick or toxic looking, you can do the 5 days. If they've had recent antibiotics or they've shown resistance to plain amoxicillin in the past, you can step it up to the amoxicillin clavulanic acid, again, dosed at 90 milligrams per kilogram per day, divided BID. Or if that's intolerable for whatever reason, you can use a third generation cephalosporin, such as ceftonir. You want to recheck these people or make sure they know that they should get rechecked after 48 to 72 hours if they don't have any improvement, because most people should turn the corner in 2 to 3 days. If they do not, that's a problem. You probably have some resistance and you're going to want to change that antibiotic to something different. There is a thing called conjunctivitis otitis syndrome. This is really popular on board questions, especially for family medicine and pediatrics. This is a specific syndrome where the patient will have otitis media as well as conjunctivitis at the same time, traditionally due to a non-typable H. influenza. And this specifically needs to be treated with amoxicillin clavulanic acid because the plain amoxicillin will not do the job in this case. So conjunctivitis otitis syndrome, you're going to want to use the amoxicillin clavulanic acid. If there's perforation of that TM, there are no studies that are recommending topical therapy alone. You should probably use orals with these kids unless they have those PE tubes. So if you look in there and you see a PE tube and it's pumping pus out of there, it's okay to just use topical antibiotics. And you want to make sure that whatever you use is not ototoxic. So we're going to want to skip the cortisporin on that. And we're going to want to use either Cipro eardrops or ofloxacin eardrops. Just a little cute little trick of the trade here. If there's a shortage and you can't find eardrops, you can prescribe eye drops and have them put it in the ear. They are clinically and structurally, chemically exactly the same. And in some cases, they're actually cheaper. So if you're having trouble getting a hold of ofloxacin or ciprofloxacin eardrops, you can order the eye drops and have the patient use those. For penicillin allergies, this is a tough one. If there's no history of anaphylaxis, remember the crossover between the two is very, very small. You can use a third generation cephalosporin, but if they're allergic to the cephalosporin as well as the penicillin or have anaphylaxis to the penicillin, then you're kind of stuck. Clindamycin, really patchy coverage. Azithromycin, very high levels of resistance, doesn't always work. So if you're going to prescribe it, you got to observe carefully and make sure that they're improving. Most patients you can discharge from the urgent care and they do well. You're not going to see them back again. But anybody with severe disease or appear toxic, you want to consider ED referral and evaluation by an ENT. Again, you want to counsel these people and make sure that they're getting better by 48 to 72 hours. My go-to sentence is, please return for recheck in 48 to 72 hours if you are not improving. This may indicate that a complication has occurred and further evaluation and treatment may be required. So make sure you're very friendly about them coming back if they don't improve in 2 to 3 days. So Joe, let's talk the same about otitis externa. How are we going to treat and make a disposition on these people?
Yeah, well, simpler decision making here. Topical antibiotics are the mainstay of treatment. You had kind of alluded to that, and not a whole bunch of choices here. And fortunately, studies show that there's not that much difference between them. The topical choices we have in for antibiotics, all pretty similar. The basic principle is to get some antibiotic in the ear in patients with acute otitis externa. You even mentioned that ophthalmic eye drops can be used in patients if there's a short supply of the typical otic suspensions or solutions. Moxifloxacin is one of my favorites for that. There was one study actually that showed that maybe acetic acid, which is one of the older treatments for acute otitis externa, may not be as effective as the true antibacterial or antibiotic. choices that we have, particularly if the symptoms are going beyond 1 week. But acetic acid's a choice in simple, uncomplicated cases sometimes. If the patient has a TM perf, you had mentioned you're going to want to avoid the ototoxic neomycin or acetic acid in those cases, but the other choices are fine. A lot of these antibiotic eardrops have corticosteroids in them as well. So we're talking about the dangers of corticosteroids, but topically, I think our bodies tolerate them a lot better than systemically. So they may contain hydrocortisone or dexamethasone, not necessarily going to lead to a cure more quickly, but they may relieve pain and canal edema a little bit better than if the antibiotic eardrops do not have them in there. So you're going to think about that in cases where the patient has a lot of pain or swelling. When they have a lot of swelling too, placement of a wick might help with penetration of the antibiotic to the deeper spaces of the ear. It's important to kind of think about how you're going to do that. It's not necessarily easy, but once you've done it a couple of times, you can learn how to do that. Most patients are going to improve within a very short period of time. 65 to 90% of patients get better within 7 to 10 days. When they're not getting better within that 2 week period, you're going to think, oh, maybe this is a little more complicated case or even a fungal etiology. If you don't necessarily diagnose that right from the start with your presence of hyphae, either grossly or on a microscopic exam, treatment failure, you're going to suspect it and get that patient off to ENT for a little bit of different treatment. They're going to need oral cleansing. And although you use acetic acid for a lot of those patients, they might pull out a topical antifungal as well, but ENT would make that choice. It's interesting. When I first read it, the issue said it's going to be important to maybe have a second person put your eardrops in. And I thought, oh my gosh, that's actually true. I don't think I've ever had to administer eardrops to myself, but I think I would have a hard time kind of not touching the bottle to the ear and making sure the drops get in there. So even for adults, having a second person there for the administration is important. A patient who's really sick, it's going to be maybe beyond our scope. A patient who's got sepsis and otitis externa, let's say. But sometimes you'll get that patient who's got diabetes or compromise, and it looks just like a little bit worse than your usual kid or adult with acute otitis externa. You're worried it's going to turn into malignant otitis externa. And that's a patient you might pull out an oral antibiotic with pseudomonal coverage to kind of prevent progression. Again, somebody with true malignant otitis externa is going to need to be hospitalized. Most cases do not need oral antibiotics, but those in between patients where you're worried a little bit worse than your usual case with risk factors for progression, that's when anti-pseudomonal oral agent might be needed. In terms of disposition, almost all of these patients are going to go home. Really ill patients or patients with extensive disease, either imaging or to the ED for that imaging and their disposition decision. For all the patients with acute otitis externa who go home, it's important to caution them to avoid moisture. Don't go swimming. They don't necessarily need to stick cotton in their ear, although a lot of patients do to prevent moisture from getting in. But in the shower or taking a bath, it's going to be important to keep that ear dry when it's in the process of getting better from this process because moisture is part of the pathology in the first place. How about pain management and any other things we might do for any of these patients, Tracy? Any tips on that?
Yep, ear infections hurt. If you've ever had one, you know they hurt. And honestly, I think externa actually hurts a little bit more than media for whatever reason, but you got to make sure that you address pain control with these people. Otherwise, they're going to come back. And usually also reasonable expectations. Expect this to hurt for a couple of days. It will slowly get better over time, but once the antibiotics kick in, it'll get better. But if they don't have reasonable expectations, they're going to think one administration of drops and they're going to be better. So make sure you set some reasonable expectations and give them some ideas of what they can do at home. I usually recommend either acetaminophen or NSAIDs. I also recommend heat, like a heating pad, hot water bottle, something like that, placed kind of under the ear or just behind the ear. Because a lot of times that'll help some of the fluid drain out of the ear and it'll also provide some pain relief. In otitis externa, the drops with the steroids in it are more recommended than the drops without steroids because it decreases that inflammation that's in there and it'll help with pain a little bit. Just say no to the anesthetic ear drops. They are ototoxic, so if there's some sort of perforation in your TM, you're going to cause a problem there. And there's really little evidence to support their use. Decongestants, antihistamines, nasal steroids, all of these things do not clear fluid from the middle ear and are not recommended at all, especially in pediatrics. Some of the steroid nasal sprays may be of some use in adults. There are a couple studies out there saying that, shrink the eustachian tube, cause some drainage of the fluid in the middle ear might help a little bit. Systemic steroids, definitely a no-no. No support for their use at all for any sort of ear infection. So just say no to the oral steroids in ears. There are some herbal remedies out there. There's some candling out there. No support for their use either and may actually cause some harm. Just FYI, those over the counter ear drops for otitis externa, they're basically isopropyl alcohol. So all they do is just dry the fluid out of the ear to try and prevent the otitis externa. So probably skip that too. If I had an acute ear infection, putting alcohol in there probably wouldn't feel too good. So let's talk about things that change your practice. So who needs to see ENT and who needs to go to the ED?
So obviously, any sick patient, we'll talk a little bit more about specifics, but some of the things that may be more subtle in terms of patients who require consultation of an ENT. If you're seeing patients with recurrent cases of either of these problems, it's important. It's fairly specific definition for recurrent acute otitis media, which is greater than 3 episodes over 6 months, or 4 episodes or in 12 months, or 1 episode in the preceding 6 months. All of those patients might have something going on anatomically and would benefit from ENT referral. It's also appropriate for patients with persistent effusion. So that serous otitis media type patient that you saw, they don't necessarily require antibiotics, but if that effusion isn't going away, they may need PE tubes or even an adenoidectomy because of that anatomic obstruction to the eustachian tube. Assorted and sundry other things that we might see in association with these infections are TM perforation, a retained foreign body that's causing a persistent acute otitis externa or ongoing acute otitis externa, and any anatomic damage to the ear, any associated hearing loss, or when you have a kid with infections that are resulting in some language delay, the ENT can handle the ear part of it, maybe not the language part of it. And then recurrent cases of acute otitis externa or ones that are refractory to antibiotics, going to worry maybe about a fungal etiology, and ENT can help with that. Sending patients to the hospital. So basically, your sick patients, patients who seem like they might be septic or have meningitis or mastoiditis, your malignant otitis externa patient, those patients are going to need more than we have at urgent care. They might need intravenous antibiotics or admission. So those are patients to refer. Also, if you have a kid who's really sick, like young and really sick with either of these, although it's going to be more likely to be acute otitis media for them if they're under 6 months and they have toxicity, that's not a patient just to get amoxicillin prescription and then send home. There's some rare things that can occur as complications of either of these ear infections. I think we probably would naturally know. But if a patient has a middle or an outer ear infection and has vertigo or labyrinthitis, if they have extension of the infection into the outer ear, perichondritis, if you're concerned that they might have an intracranial process because they have altered mental status, and lateral sinus venous thrombosis can complicate either of these infections. And then the paper actually cites Gradinego syndrome, which I had never heard of, but I think I'd be worried about this patient. That is infection of the petrous bone with an associated triad of acute otitis media, pain in one of the branches of the trigeminal nerve, and an abducens nerve palsy. So if you have an ear infection and you can't abduct your eye, that patient needs to be referred. I think I'd probably do that just naturally, even if I didn't know what Gradinego syndrome was. Special populations, I think we talked about most of these when we hit on them in the different sections, but kids who are unimmunized for pneumococcus, you're going to worry a little bit more that they might be affected by H flu. Even if they don't have the conjunctivitis, any kind of sick kid with otitis media who's unvaccinated, you're going to worry about worse pathogens. It's going to be important in considering the special populations, those age groups that you talked about. Not everybody's a candidate for watch and wait antibiotics. The really young are not. And then in that intermediate age, if they have severe or bilateral otitis, you're going to want to consider them a special population, not a watch and wait candidate. Kids who have PE tubes, again, you don't necessarily need systemic antibiotics when they have otorrhea. You can get by just with topical. And then finally, our pregnant patients, I think we think of them as a special population when we're making antibiotic choices because we don't want to give them anything that's going to hurt their baby. So, Trace, let's talk a little bit more about the watch and wait. I think that's one of those things that's changing our antibiotic prescribing, but it's not, oh, you have otitis media, why don't we see how you do for a couple of days. We have to kind of follow a specific patient selection for that and a special process. Can you explain that more?
Right. Yeah. I've been doing a lot more of this. And actually, according to the American Academy of Pediatric guidelines, it's actually really recommended. Pediatricians are doing this a little more, probably not as much as they're supposed to be. But because of the episodic nature and because we don't really have an ongoing relationship with patients, we're less likely to do this out of urgent care or out of emergency department. So, something we really should start to think about doing more of. This was surprising statistics to me. 81% of children with acute otitis media are going to get better whether you give them antibiotics or not. 93% are going to get better if you give them the antibiotics. And it really improves the pain more in 24 hours if you get the antibiotics. It takes 2 days if you don't get the antibiotics. So, if you can stick it out with some ibuprofen, you can give it a chance to see if it gets better on its own. Obviously, less adverse events in the antibiotic group because you don't get the allergy, the diarrhea, the vomiting, whatever else. You don't have to wrestle the kid to give them the antibiotics. Anybody who's ever had a kid that doesn't like taking meds knows that it's a challenge just to give some of these kids antibiotics. The rate of complications is the same in both groups, so you're not risking some horrible spread of disease if you watch and wait and don't give them antibiotics. So the only caveat to that is any kids under age 2 should be treated. So it's really just for the older toddlers and the older children that you can do the watch and wait thing, and also not recommended for adults. You want to discuss with the parent and guardian and make sure that they're reliable and that they have adequate follow-up if they're going to watch and wait. If you get the sense that the parent is not willing to do this, you might just want to go ahead and give them the antibiotics. You also want to consider what's called a SNAP prescription. I call it delayed prescribing. So you give them the prescription for the antibiotics, even though you tell them not to start it right away. So I'll usually give oral and written strict precautions on this is when you give the antibiotics. They're not getting better in 48 to 72 hours. They get worse in 48 to 72 hours. They start getting pus coming out of their ear, or the pain is severely uncontrolled, even with the ibuprofen. Go ahead and start giving that antibiotic. Otherwise, you can hold off on it. And studies have actually shown that about 40 to 60% of people will not fill that antibiotic and will not give it. So most of us will say, oh, they're going to go fill it as soon as they leave the department. Who am I kidding? But the truth of the matter is they really don't. If you have a reliable person, they will do that watch and wait. There's no evidence in doing any of this on adults, although for sinus infections, I tend to do it in adults. But for ears, right now, it's recommended to just go ahead and treat them on adults and don't do the watch and wait. So now let's talk about 5 things that'll change your practice.
You bet. Well, hey, penicillin allergy, our focus on antibiotics is in decreasing our antibiotic use and picking the right treatment and as narrow a spectrum as possible has led to a lot of focus on this. Oh, yeah, I have a history of penicillin allergy. Sometimes you'll even get the patient who said, well, everybody in my family is allergic to penicillin, so they report it as an allergy for themselves, even though they've never had a reaction, just like everybody in their family did. So it's important to dig into that because we want to give the right antibiotic, the right spectrum. And if a patient has a penicillin allergy and acute otitis media, you might have to go to maybe an antibiotic that's not as good, not going to be as effective, or maybe have a too broad of a spectrum. So dig into that history of penicillin allergy. You can even use a decision aid called the PenFast rule. The issue didn't talk about that, but that's one of the available tools that we have to determine, hey, can I maybe not prescribe penicillin for this patient, but a cephalosporin and obviously a patient with documented anaphylaxis to penicillin, you're going to avoid all of that. But do dig into it and get patients the right antibiotic rather than just moving to a broader spectrum one just because in their chart there's this history of penicillin allergy. For almost all cases of acute otitis externa, you don't need oral antibiotics. Topical therapy is adequate, and your clearly uncomplicated cases do not need oral therapy. Make sure you educate patients regarding ear care, administration of topical antibiotics, avoiding moisture. All of those things may not be intuitive to them. So it's important for us to take a little extra time to do that. We talked about the indications of referring to ENT or onto a higher level of care in the ED. A patient needs imaging, if they're sick of hearing, if you're worried about a complication, our referral for ENT or similar, or patients just with recurrent or refractory infections. Make sure you're doing those things to ensure proper care of the patient. And then Tracy talked a lot about the watch and wait. Once you know the criteria for that and use some shared decision making, that can change your practice and decrease your overall antibiotic use if you follow those guidelines. So how about some points and pearls, Tracy? We got some points for us?
All right. So really quick, we're in the home stretch here. I want to wrap this up. So remember we said clear understanding of the types of otitis media is critical. So if it's serous otitis media, you want to be able to recognize that so you don't give antibiotics and avoid that antibiotic overuse. Acute otitis media, remember it is infection, so you have to have inflammation and pain. Congestion usually due to a viral upper respiratory tract infection, whereas the externa is due to moisture in the ear canal. So 2 totally different mechanisms of how this stuff happens. So you can figure it out by history alone. You don't even have to look in the ear. Well, it's a good idea to look in the ear to make the diagnosis, but you should know before you look in the ear what you're expecting to find. Otoscopic exam, absolutely essential to this to differentiate all the different varieties. Don't forget about your pain management. This stuff hurts. If you've ever had an ear infection, you know it hurts. So make sure you go over not only just saying, take acetaminophen or an NSAID, but actually going over the doses. I can't tell you how many people tell me, well, I took one over-the-counter ibuprofen yesterday and I'm still in pain. So you got to go over the doses with them. High-dose amoxicillin, first line for otitis media in children, acute otitis media. Want to make sure you get that 90 milligrams per kilogram in. If that has been used frequently or recently, you want to step it up to amoxicillin and clavulanic acid if they've had it in the last month. And don't forget about the board question, the conjunctivitis otitis. That's supposed to be treated with the amoxiclav as well. It's also first line in adults. Third generation cephalosporins can be used if you have that penicillin allergy that Joe just talked about. If you're stuck and can't use cephalosporin or penicillin, amoxicillin, then you're stuck with clindamycin or azithromycin. Not a great choice because of resistance, but sometimes you got to do what you got to do. Treatment duration, 5 to 10 days based on severity of illness for both kids and grownups. Children under 2 should be treated for a full 10 days. And again, I think we've drilled this into you already. Anybody who has a complication, you should be sending them to the hospital. Anything else? Any pearls?
Yeah, a few pearls before we wrap up. Just to summarize again, either the safety net prescription or a true watch and wait without antibiotics for 48 to 72 hours. Consider that in your kids over 6 months. So that would be a 6 month to 2-year-old with unilateral non-severe, or a kid over 2, even if there's bilateral otitis media, as long as it's not severe. This is not recommended or been studied in adults, so you don't necessarily want to do it there. And remember, adults have a higher rate of complications for their acute otitis media. You're going to choose your antibiotic for acute otitis media based on your suspicion of the type of pathogen, whether there's been recent antibiotic use of some sort, if there's been a prior treatment failure, the patient's allergic history, and then the vaccination status of your child or even adult. So remember those things. For acute otitis externa, if there's concern of a TM perforation or a history of tympanostomy tubes, you're going to want to use fluoroquinoline eardrops for that, avoiding the ototoxic neomycin and acetic acid. And then consider drops with corticosteroids because those have been shown to improve pain and inflammation. So your more severe cases, use a combination drop of that sort. And how about a wrap up, Tracy?
All right. That wraps it up for this edition of Evidence-Based Urgent Care, talking about otalgia. We thank you very much for listening to us, and we hope you learned something or reinforced your practice, and hope you have a great day.
Yeah, hey, be sure to check out the monthly subscription on this topic for more info than we had time for here. That includes billing and coding, tidbits, clinical pathways, and more. Thanks for listening.
I want to thank everybody for listening to this month's Evidence-Based Urgentology podcast. Just a reminder that subscribers can go to evmedicine.net and read the full issue if you want more information, if you haven't already.
And if you're not a subscriber, head to the site, that's evmedicine.net, to check out what they have. If you subscribe, you'll get access to the article, as well as future articles and the whole archive of all past issues.
Look forward to seeing you there.